what we're going to get you to do is over here on your happy leg first, I want you to keep your big toe on the ground, but try and lift your second to fifth toes up in the air while keeping the rest of the foot down, and then relaxing down. Good, go again. And back down. Now for people that are struggling, you might use a prompt on there. Come as close as you want to, guys. And if they're really struggling, you might even put a book or something down. But Toby's not doing too poorly there. Now, Toby, from there, let's keep your second to fifth toes down and try and lift your big toe up and down. Yep. Nothing like having your feet shot at close range either, hey? Good. Now, the third position, Toby, I want you to lift all your feet up, all your toes up in the air. Keep that big toe up, and then we're going to wave goodbye with your second to fifth. And I'll remove my fingers, and this is where it gets quite tricky. Not doing too poorly at all, though, Toby. So we're going to go over to the symptomatic side. So Toby, let's try that over here now. Keep the big toe down, lift second to fifth. Good, now let's reverse it. Keep second to fifth down, try and lift big toe up and down. You're playing the game well. No, yeah. Now from there, if a patient's struggling, I call that like position 2 for simple terms. I wouldn't ask them to do position 3 because it's just like, all right, Toby, try and get all your toes up, keep your big toe up, wave goodbye. It's normally just going to be a little bit too much. Now, in terms of explanation for this, this can represent some degree of like smudging in the motor homunculus in the brain. So it's literally the brain. We know it's plastic. So it's plastic. It's neuroplastic, highly adaptable. So in patients that have had a long-standing history of pain in the shank below the knee down or the foot and ankle, you will often see foot control really struggling. And in my opinion, whether it's a calf strain injury or medial tibial stress syndrome or tibial bone stress like we're talking about tonight, or a post-traumatic ankle fracture, we really want to make sure we get the brain of the patient, athlete, reconnected to their foot. So I'll send them home for this. Could be 2 to 3 sets of 10 reps working through those. They'll often feel quite frustrated. Now, while Toby's also in this, until they get it, that is, and I also like to let the patients know, hey, this is not forever. This is just to get your brain re-recognizing your foot in simple terms. Remember, we're doing this to help the shock attenuation capability of the foot, which is a treatment strategy for reducing work at the symptomatic tibia. While in this position, I like to get a bit of a check for flexor hallucis longus, FHL. So Toby, I want you to keep your heel on the ground without clawing your toe. Just push through your big toe there into my finger without lifting the heel as firmly as you can, and relax. And go again. And relax. Now this is a subjective way of assessing it. Compare it to the other side. I give it a simple manual muscle test out of 5. So I'm going to score Toby over here. Go Toby. So let's play the symptomatic game and call that a 1 over here, or 2, and this one might be a 3. You'll often feel differences with symptoms side to side with a flexor hallucis longus test.